Yes, our first speaker is Dr.Sudha. Most of you here in the audience know her, but I still have the privilege of introducing her. She's the co-founder and medical director of Eternesse Medical Center, Hyderabad, India. Doctor of Medicine from Baylor College of Medicine, Houston, USA. Certified and registered member of the NEM Pro, Cambridge Summer School in Applied Human Nutrition. Speaker, Indian Nutritional Medical Association, faculty member of the Saukhya Training and Research Institute, and currently practicing as an integrative medicine physician with goals of preventive, regenerative, and functional medicine at the Eternesse Medical Center in Hyderabad, India. Dr. Sudha, the floor is yours.
Thank you, sir. Thank you so much for a great introduction. Thank you, Dr. Lenny. Right, most of the people know me here. Okay, so the beautiful way of Dr. Kamal Kal putting the hormones, a single line, is molecules which flow. Hormones cannot be put in a single word in such a beautiful way. So that's how I take privilege to be here. Thank you, Dr. Sreekumar, again, for giving me this great opportunity. It's always great to be with this team, and it's always looking forward to something new. And in this time in Mysore, it's a great panel. Started the integrative cellular nutritional medicine. Everybody introduced the course in a very, very beautiful way, and I hope we all follow through. So hormones. So thank you so much, Dr. Kamal Kal, for choosing me for female hormones here. So female hormones is what I'm going to talk about right now. Can everybody see the slides? So when we're talking about women's health, it's always the female hormones and the stress that comes with, that controls the hormones. The fountain of youth, the idea of eternal youth is not something new to us. It's always been there when you take past history of 16th century all the way, how important that is. If we as physicians, and I see most of the female physicians here, is we as physicians, if we don't address this, keeping everything in mind, what the female goes through, we will be doing a very, injustice to the community and injustice to the society, because it's mostly in our hands to understand this from as a child to menarche, to puberty, to menopause. Because if we address this issue and understand every hormone which runs through it, we can prevent many diseases. We can prevent cancer too. So when we are talking about only as a treatment medicine, here I want to address how many diseases that we can prevent when we are, when we talk in these female hormones and in depth. So these are the phases of life. I know, people in India, they are very shy to talk about these female hormones and female issues when they come to the doctors and physicians. It's our responsibility to make them at ease and to talk about these issues, about hormones, stress-related hormones, menstrual irregularities, menopause issues, puberty issues, and depression. If we don't address this way as early as a child, to the postmenopausal, we will continue to increase the mortality as well as morbidity of the population. So I would like to address this in all ages, from the menarche to the postmenopausal. As early as much as possible today, we are seeing in our girl childs. I also have a daughter, so I know how much, stress that if a child is going through a menarche at the age of 8, how much at 6 years old. Recently I came across a child who's at in menarche at the age of 6. And I'm like, okay, something is going wrong somewhere. If we don't address these issues as a hormonal imbalances is causing premature menarche to premature menopause, we will be doing an injustice to the society, making these same kids causing cancer at that late age. So as much as I started looking at pediatric patients also in this way, when they come for their vaccines or when they come for their flu, I make sure that I address that they attain menarche a little bit on the normal curve, which we always thought the normal curve is 13 or 14. But today, 9 became the normal age. 9. And if we don't address the way we need to address, it's going to become 6 or more earlier, which is the body is not ready. But due to the food, due to the habits, due to the stress that the kids are going through, that's where the prematurity is coming to the ovaries and all that. So as always, we know this graph in our medical schools, the low but possible is 9 to 13 today. Today it's 9 to 13. When I was in medical school, it was 13 to 16. So the graph is going more lower and more lower from the menarche as well as the menopause. So that's why I took this, when I said hormones, I take it very seriously when I talk to my patients about this. Now, what is the other condition that made me think a lot about females and its hormones? The only one condition people are coming with this single complaint is depression. As early as a teenage depression, as early as an adolescent depression, as early as adult depression, to a postmenopausal depression. There was a single utmost complaint all the way. Symptom, I should not say complaint, but it's the symptoms of depression that as early as teenage. When I opened my newspaper in India, we see a lot of teenage suicide. I've seen a lot in this for the past 5 years. There is an increased amount of suicidal deaths in the colleges, in the schools, everywhere, because there's so much of stress, there's so much of burden in the colleges and the schools for them to keep up the pace. Keep up the pace with the colleagues, keep up the pace with the parents, keep up with everything. And when they're so much in a stressful phase, all the hormones are going to be imbalanced too, because the food is not right. So this is the utmost symptom that I keep up with every day in every age group, that I started addressing hormones as a root cause of depression. Now, when we look at the stage of adolescent development, in all countries, adolescents go through the same stage, but the age range varies. So in USA today, it is 10 to 13, as much as, in the middle adolescence is 14 to 17, and the late adolescence 17 to 21. Different in these 3 stages, we have seen lots and lots of depression. This is where in US kind of a background and a setup, this is where we see shootings in the colleges, shootings in the schools, which we all hear about in the newspapers. But that became a threat. That became quite a big of responsibility for the doctors as well as the youth population or the schools, the counselors, everything. Because everybody is going to a tremendous amount of imbalances in every way. Now, in this adolescence, what is the most common thing that we keep up with? Everybody today is PCOD, PCOS. I'm sure there are many gynecologists here, and I talk to my colleague gynecologist, and there's I see 100 patients a day, and 80 patients I diagnose as PCOD. I was like, that is ridiculous. I mean, sorry to use that word, but that is the situation today. So PCOD is a global epidemic coming to the female population. So why is that? That's what we want to address today. How can we prevent this? When we were in medical schools, it was 1 in 30. That was hardly there in the textbooks of PCOD. Today, everything is a PCOD in a female population. So the most common endocrine dysfunction of women affects up to 25% of the women. A lifelong disease. It is a lifelong disease when it comes to female hormones. They can be diagnosed at an age of as young as 10 to 15 to, again, 20 with infertility caused by PCOD, then premenopausal, perimenopausal, early menopause at the age of 35, and 45 at the age of same thing. You still have PCOD. That became a norm in the diagnosis today as PCOD. So how is it a lifelong disease? It's an enormous medical, emotional, as well as the financial consequences of this diagnosis. And it puts a high risk for diabetes, metabolic syndrome, infertility, and overweight and obesity. So when we have one single diagnosis leading to multiple diagnoses on the pipeline, shouldn't we address the PCOD than addressing the diabetes or overweight or metabolic syndrome? Can we prevent all this by addressing as early as when they walk into our clinics at the age of 12, 13, and 14, so that we can prevent diabetes, so that we can prevent metabolic syndrome? So as everybody knows, they just say that, there's so small cyst in the outer edge of the, this is a very common definition. But I don't disagree. I totally disagree with this kind of a definition. Yeah, there are some cysts. Okay, you're PCOD. But what is going on behind the cysts is what I would like to talk about this. So this is a normal follicular phase and the luteal phase in the menstrual cycle that we all know. If we understand this graph to day, we can prevent many things. What is estradiol? What is progesterone? What is the follicular phase? How many phases of the follicular phase we have? And what are the hormonal imbalance by week? What kind of mental to the emotional drainage that is going through with these two stages in the menstrual cycle? And if we pay attention to these phases of cycle, we can address many issues. So starting with the female hormones, it's estrogen and progesterone. These are the two hormones that we cannot address hormones without discussing about this. So during the reproductive years, ovaries makes high amount of estrogen beginning at the peaks at the beginning of the cycle. Progesterone peaks after the ovulation. So anybody who walks into the clinic saying that I have a 15-day cycle or a 18 to 20-day cycle, it automatically should click that they have progesterone deficiency. If they're saying that, okay, I'm not even, no menstrual cycle for 2 months or 3 months, they don't have both the hormones. So the FSH and LH is high. So if these simple two hormones, if we keep it in mind, then we can address the female issues. And there is a small amount made by both adrenal gland, and some estrogen is also made in the fat cells. Today, obesity that's what it is. Our fat cells are also making the estrogen hormone. That's where high estrogen is there, and that's why you will know what it is. So coming into the biochemistry. So the biochemically, what is going on from the follicular phase to the luteal phase, everything. So this is the simple biochemistry. If we can understand from a molecular level, from a biochemistry level, it is very, very easy to put them all together. So in an early mid-follicular phase, in the GnRH, comes from the brain to the pituitary gland, FSH and LH, and there are two types of cells called theca cells and the granulosa cells. So what happens is the theca cells is the culprit for most of the things. So the theca cell starts producing a lot of androgens. So but the androgen is supposed to go to the granulosa cells to produce estrogen. So most of the things, this is a normal menstrual cycle. So please understand, this is the normal way that the hormones should function. Then in the next slide, you will know what is the abnormal way which is functioning this way. So there is a positive and the negative feedback you need to understand. And then later in the follicular phase, there is high amount of LH, which causes high estrogen output, and there is something called inhibin. So we always misunderstand or we don't address from an inhibin hormone, which is equally responsible and produced by the granulosa cells. And the later point where after the ovulation, which is in the luteal phase, the corpus luteum forms. So the corpus luteum are the cells that are left back. So the 3 or 4 hormones kind of mature, or 3 or 4 cells ovum kind of mature, and the corpus luteum, is the rest, is the left behind ova, which are not be able to mature. So they form together, form a corpus luteum. This is where the problem is. The corpus luteum should be producing more estrogen, progesterone, and inhibin, which is again controls the FSH and LH. So when the corpus luteum stops hormone production, this is where the PCOD is. There are too many cysts getting mature, and then most of the people are immature. So when the immature cells are too many in the cyst formation, they can't produce estrogen, they can't produce inhibin, they cannot inhibit the FSH and LH. When the inhibitory mechanism and the negative feedback mechanism interferes, then you continue to have a PCOD. So this is exactly what is happening in the left side of the slide. If you can understand this one mechanism, which is from the theca cells you're producing androgen. From the androgen, there is an enzyme called aromatase enzyme. which has to go into the granulosa cells, causes inhibin and the oocyte development. Lack of granulosa cells activity causes, the oocyte is not getting developed. This is where the biochemical imbalance is there for the PCOD. So in the PCOD, the overactiveness of the theca cells will happen. Underactive of the granulosa cells will happen. So overactive of the theca cells causes more of androgens, and more of androgens give us this hirsutism and acne, and then the androgens in this phase can convert into the form which, so there is a biochemical variation in the production of estrogen from the granulosa cells and from the androgen. So the androgen produced converting into estrogen is going to interfere with the anterior pituitary hormone, and this androgen by aromatase in the body tissue. So that's where the fat cells and the estrogen is coming from the fat cells and not from the granulosa cells, which is a different form of biochemical reaction of estrogen. And that's where again insulin. So you cannot address any female hormones without keeping insulin in mind, without keeping thyroid in mind. These go hand in hand. And if we don't address thyroid as well as insulin, we will be failing cases. That's what the normal conventional therapies are doing. They're just concentrating on metformin and spironolactone for the treatment of PCOD, which taking care of the immediate symptom but not addressing the root cause. That's where the imbalance is that the people are ending up on metformin lifelong. But you're not addressing the root cause. You're just taking care of the androgens converting to. But you're not converting the androgens into the granulosa cells and producing your progesterones and estrogens. That's why the conventional, we agree, everything is researched and agreed, but something is not working. That's where it's like something, the spironolactone, I prescribed so many things. It's just giving me a symptomatic relief of hirsutism and acne and metformin, but my menstrual cycle is not getting better. The hormones, the people are not losing weight. The hormonal cycle is not getting better, but that PCOS, the cysts are still there. This is again another slide that you can, easily get addressed, because there's another hormone from the DHEA. Without addressing DHEA, you cannot think of addressing the female hormones too. So adrenal gland, adrenal fatigue, they all go hand in hand. Today I changed my practice so much in this 5 years. DHEA became a part of a protocol in testing as well as management. So without DHEA, because the mother of all hormones, I'll show you another slide where the DHEA is important, because again, going back to the cholesterol cycle, if the cholesterol is high, they're already on statins. If they're already on statins, my DHEA is not going to form from any cholesterol. When there is less DHEA, I'll show you another slide of that. You can address, much better, but I'll go back and come back. So this is where my DHEA is coming. It starts with the cholesterol. Sorry to say, but it starts with fat. We need fat. But it's the confusion in fats is, what is a hydrogenated fat, LDL, VLDL, HDL. There's a lot more confusions from the physician point of view, from nutrition's point of view, from everybody's point of view. Then the cases end up in a chronic phase with us, saying that, okay, I'm treating the cholesterol somewhere, but my hormonal imbalances are there. Without the cholesterol, there is no DHEA formation. Without DHEA, the normal estradiol and the normal progesterone functions and the normal cortisol functions cannot function. If we don't address this cycle with this biochemical way, then only we see a lot of failures. Then only we are also upset and we are also not happy with the way we are treating our patients. So that's why I'll come back to that slide. I just wanted to bring up that. And when the DHEA S is also imbalanced, then the androgens go up. And the androgens coming to aromatase, and there is a E2. So there is different types of estradiol. I saw in the lecture somebody's talking about estrogen for the female, so I said, okay, that's a good topic to choose tomorrow, because there are different types of estrogen. Estrogens, yes, we are scared to replace estrogens, but you need to know what is the good estrogen, what is the bad estrogen that can cause cancer. The bad estrogen that can cause cancer is E2, which is the estradiol. So that's what we want, to decrease the estradiol formation. but we want the estrione and the estriol. That's where the testing, not many labs are testing these differently, but this is what if we can keep in mind and test the estradiol, then we'll be addressing a lot of these things. So from the androgens, they convert into DHT. So most of the PCOD people come with hair fall. So there's dihydrotestosterone too much because of there's too much of androgen. Again, insulin resistance. There's increased insulin. There is bioavailability of E2 is high. Bioavailability of testosterone is high, and insulin growth factors are also high, which indirectly suppress the FSH and LH. And so, these are the imbalances that we need to pay attention to. Again, the estradiol needs to convert into estriol. For the bone, why are we seeing osteomalacia? Why are we seeing so much of osteomalacia in the elderly? Why are we seeing a lot of fractures in the elderly? This is the root cause, the female hormones of the root cause, because the estradiol is not converting to estriol. There's too much of estradiol in that, which has been attracted to the breast cells, which is attracted to the other organs, which can cause cancer. Estradiol is good, but it needs to convert into estriol, which is good for the bone. So these are the most common symptoms that we come across: excessive hair growth, weight changes, trouble losing weight, ovarian cysts, low sex drive, irregular missed periods, thinning hair, high testosterone levels, insulin resistance, fatigue, acne, mood changes, and trouble conceiving or infertility. These are the cases. Every female, if we have a chance to address any of one of this, 80% of our OPD will be one of them. If we don't have time to address, 80% of the female patients are going through one of these. So this metabolic effects, how they end up metabolic effects, is the hyperinsulinemia, impaired glucose tolerance, dyslipidemia, visceral obesity, overweight, obese, hypertension, endothelial dysfunction. If perimenopausal, I'm going to come to menopause, when your menopausal cases always end up hypertension. They come with hypertension. So we need to address new onset of hypertension too. New onset of endothelial dysfunction too, new onset of insulin resistance like diabetes. We need to address estrogen and progesterone, because indirectly we are addressing their hypertension, and indirectly we are addressing their diabetes. Indirectly we are taking care of the metabolic syndrome. So every person who walks in with a new onset of hypertension and a new onset of diabetes, please address their hormones. We address their hormones, indirectly the diabetes is going to get better, because we're going to push their oral hypoglycemics, insulin, and we are not getting anywhere, because the root cause is somewhere else for the females, and not less than for males too. Dr. Sunita is going to talk about testosterone, which is equally important. So that's where we need to address for the hypertension and diabetes too. As family physicians or an internist, we have a wide range of patients coming through, and we can do so much to the society if we keep our mind open. So estrogen deficiency and chronic inflammation. Estrogen is the master for metabolic homeostasis. We are scared one side of the estrogen because estrogen can cause cancer, and one side we are over-suppressing or overstimulating. The one thing that I noticed very significantly for the past 10 years, which changed my mind, is the plastics that we are using a lot. The plastics, which I'm going to talk about toxins tomorrow, which is going to be another whole segment, that if we don't address environmental toxins as much as Dr. Sreekumar is trying to keep up, if we don't address that, we will be again not be doing any good to as a medical fraternity. So BPA alters estrogen receptor function. Any BPAs, which is free BPA, we have the children which are using for the artificial feeds from the plastics that they are drinking the milk, can alter the estrogen receptors. If we can keep this one chemical in mind of environmental toxins, we can change a lot, because that is interfering with the estrogen receptors. BPA alters estrogen production, function, along with progesterone production, melatonin receptor function, as well as thyroid receptor function. Why we are seeing so much of hypothyroidism? Why we are seeing so much of Hashimoto's? Why out of 10 girls we diagnose them of hypothyroidism? Because they are altering, the receptors are being altered by the environmental toxins. So if we don't address or if we don't educate our patients with the environmental toxins causing hormonal imbalance, causing metabolic syndrome, then again our knowledge and our prescription medications are not going to go in long run. So today there is chronic inflammation as well as estrogen deficiency. I mean, did we expect this? No, we did not. And there is estrogen deficiency today with chronic inflammation. Everybody's HSCRP is high. Everybody's homocysteine is high. Everybody's apolipoproteins are abnormal. Lipoproteins are abnormal. So there is a constant amount of chronic inflammation. Now, what is the reason for this chronic inflammation is what we need to address. So that is one. So I'm talking about issues that we can be interfering with our estrogen progesterone. The other is gut microbiome. I mean, this is my favorite topic. Most of the people know. Everything starts in the gut. Now it's a in thing all over globally. Physicians are looking into it, and glad physicians like us are pushing them, and then we are addressing them and we are looking into it. Poor dysbiosis of gut microbiota. This is the main culprit for hormones too. So we have to address their gut. We have to address their toxins. So poor diet leads to gut mucosal permeability, passage of lipopolysaccharides from gram-negative colonic bacteria into systemic circulation, activation of immune system with release of cytokines interfere with insulin receptor function, increasing ovary production of androgens. Because I said, if androgens are good and they are producing by theca cells, then from where are the androgens are producing too much? That's the question I asked myself. So other than the theca cells, where are the androgens coming? So that these androgens are giving us histiocytism and acne. It is the inflammation. That is the inflammatory cytokines interfere with insulin receptors functions as well as production of androgens, altering the normal follicular development. So it is the outside toxins which is coming into our gut. Due to the gut impermeability, the mucosal permeability is interfered and ending up in follicular changes in our ovaries. The new ideas. So what are the doctors like us? The new ideas of PCOD than the conventional ideas says complex interactions between genetics and the environment. So today, thanks to Dr. Sreekumar, always addresses about epigenetics. This is we are getting ahead, going ahead with another 10 years of medical field. Epigenetics and environmentals and genetics is the in thing that we need to address. Exposure to endocrine disruptors, which is like a BPA and a lot more. Abnormal hormone receptor functioning, oxidative stress, beginning in utero. So I looked up a study saying that in utero, the female, fetus are getting exposed to BPAs as well as in utero, and the folliculars are changing in utero. So gynecologists and obstetricians especially has an equal role. Obstetricians have an equal role to educate them about toxins and about everything. And gut inflammation and systemic inflammation and prenatal hormone fluctuations within the womb. So infertility, they come up with infertility, then we give all kind of IVFs and everything like that, which is again interfering with a normal mechanism. And then we have a child, it's beautiful, I have a child after so much of infertility. But the kind of exposures that we have, the follicles of the female fetus is already interfered in the womb. So prenatally, when they're coming for many of the obstetricians are there, prenatally, we have to think of the female child which is going to come out. Is autoimmune disease, especially thyroid, skin tags, darkening of the skin. The dermatologist, the reason I jumped into dermatology department, okay, and then just because I want to diagnose from the skin to hormones to start with. Skin tags to acanthosis nigrans is the sign of metabolic syndrome. If skin tags, they come from a skin clinic, they come for removing of skin tags, I address their hormones. People think that she's crazy. I came for skin tags and she's talking about hormones. I said, that's how I am. I'm sorry, I can take care of your skin tags, but I need to address your metabolic hormones. IBS, leaky gut, arthritis, tendinitis, depression, anxiety, stress, vaginal infections, sleep dysfunction, obsessive sleep apnea 2, and cancer. So these are the autoimmune related issues. And so what are the inflammatory laboratory testing? So everybody is testing only for the cysts and PCOD, but you have to take care of how much inflammation is there which is causing that. Most of these things are not being, it's very expensive in India, but at least homocysteine and hsCRP and oxidized LDL. These three are more than enough. We used to test the myeloperoxidase enzymes and as well as isotryptanes, but it's very expensive here. But these two, hsCRP and homocysteine, is enough to address the inflammatory hormone. Just now we were talking with Dr. Sunita how to reduce the hsCRP. So that's where these two are enough to say if their hormonal imbalance is causing due to the inflammatory factors. Again, additional testing, advanced lipid testing, and TSH, free T3, free T4. Today, anybody who walks into my clinic for thyroid, I don't send them without testing anti-TPO and anti-DGB antibodies. Without testing the antibodies, we cannot address thyroid issues. It is better to explain the patient how important they are. If they can afford it, it's fine. But it's better, late than sorry. It is important to address anti-TPO because those are the inflammatory markers. That's where the inflammation is. That's where the thyroid imbalances are coming. That's where the inflammatory markers are so high. So most of my thyroid patients, I'm very flexible to take them off on their thyroid tablets once I address the nutritional and the anti-TPO. Dr. Sunita, I think you're talking about thyroid, so it will be great insight from her. Again, insulin and 2 hours OGT, uric acid. Uric acid just surprised me for the past 5 years. We were always taught uric acid is by meat eaters and protein eaters. Today, every vegetarian person is having high uric acid levels in the blood. Sorry? It's foods, that's right. Everybody, I guess we were taught to address uric acid as meat. That's what we were taught. Oh, you're eating too much wheat. I swear I don't eat meat, and the uric acid is 7 and 8. It is the foods, Dr. Lenny has said, it's the foods, and then we need to address the uric acid levels as well. And most of the PCOD people came back with high uric acid as young as 16, as young as 20. Uric acid became a very, very main inflammatory marker in our inflammatory screening. And vitamin D, everybody knows now how much important the vitamin D is. B12, omega-3 index, if you can, DHEA, testosterone, estradiol, progesterone, and SBN, anti-Mullerian hormone, FSH, and MTHR genes. MTHR genetic testing has also become a very, very, normal thing nowadays. So this is the way functional medicine testing is done. This is the way functional medicine practice is done. If you want to be, address this, then check the gut, check the nutritional status, check for environmental toxins, heavy metals, check the adrenal stress, gluten antibodies, food, environmental allergens, and autoimmune status. If you're going to check this, then only we're going to address in every way, and the patients are going to be happy, and we are going to prevent most of the things. So conventional treatment, as I already talked about. So what are the side effects of the conventional treatment that we were taught, and I practiced for more than 10 years, before this 8 years, I used to prescribe a lot of metformin, and I used to prescribe a lot of spironolactone in my initial stages. Oh my God, no way. That's 1 hour.
30 minutes.
No, they told me it's 1 hour. Sorry, sir.
Okay, carry on.
Okay, sorry. I just read it. Yeah, Accutane causes depression for skin. Spironolactone is inconsistent benefit that we have seen. Metformin, again, it interferes with our gut health and B12. And bariatric surgeries. Today, everything bariatric surgeries is nutritional deficiency. Bariatric surgeries is a quick fix for the obesity and for the metabolic syndrome, but it's a very big, very bad thing. Conventional, okay, so lifestyle. So this is a physical exam, is absolutely important. Acanthosis nigrans, skin tags, to hormone testing of metabolic markers, nutrition and gut health, and life changes, nutrition, stress, sleep, hypnosis, massage, and all that too. So this is from a nutritional point of view, from an integrative point of view, treating the epidemic as well. So yes, there are too many medicines. Yes, there are too many supplementations, but these are I wouldn't say organic or natural, but these are anti-inflammatories. We don't want to use COX-2 inhibitors as anti-inflammatory. We don't want to use other anti-inflammatory, but we have to use some anti-inflammatory which doesn't cause side effects. So we have to we have to know what are the adrenal adaptogens. The adrenal adaptogens is ashwagandha, rhodiola, holy basil, and ginseng. When the adrenal issues are there, and it's the chromium and the probiotics for the gut health, and N-acetylcysteine. I'm using a lot of N-acetylcysteine in orally as well as myo-inositol because it's fatty liver, so we have to address that. Sorry for the slide. So aloe vera, chlorellas, again flax seeds, probiotic blends, amino acids. Amino complex acids has helped us a lot because I'll tell you, the meat that we are eating today has deficiency of amino complex. So it is calories. It is the meat has only calories, but it doesn't have any nutrient value. Yes, we are eating meat. Yes, it is not about how much meat you are eating or how bad. It is the type of meat. Eating meat is not bad, but it is not fresh because it's the refrigerator. Thanks to the refrigerator, it's keeping my meat rotten for so many days. And then when I cook, again, there is no nutrition in it. So all my amino complexes are disappeared from the meat. So there's no point of me eating meat because, again, I want to cut it fresh. I'm in India. That's why I'm thankful to be back. I can get my meats fresh. I don't refrigerate. I cook within 6 hours. And if my son is eating half kg of a meat in 6 hours, I'm happy about it because I'm giving him nutrition and I'm not giving him stored dead hormone. So this much is eating meats. Always address don't eat meat, don't eat meat, don't eat meat. It is the type of meats. When it is cut, when it is processed, how it is processed, it's part of the toxins, the environmental toxins that we're going to talk about. The real gut microbiome and the cruciferous vegetables and berries and low protein and animal protein, that's what I talk. Healthy fats on only, not too much. Again, educating ourselves with healthy fats. Healthy fats is the cholesterol. Today, why we are having high cholesterol formation? Because body cells are intelligent enough. They don't take hydrogenated fats. They don't take. So the body is struggling to make healthy fats. That's why we have high cholesterols in our blood test today, because body is not getting healthy fats. They are forced to make cholesterol so that it is natural. Again, when the body is making actually biochemical way, it is natural, as Dr. Kamal Kal said. When it is natural, it is similar to the biochemistry of our natural hormones. So why it is not taking the cholesterol from outside and making the DHEA? Because it doesn't mimic the natural hormone. So the body is forced to make cholesterol, which mimics the natural, chemical reaction, which can make DHEA, which can make testosterone, which can make estrogen, which can make other hormones. So the body is forced to make cholesterol because we are not giving any natural cholesterol anymore. So coming to the menopauses, there are 3 stages of menopause: perimenopause, menopause, and postmenopause. Please keep in mind the adults from 30 until 30, if they are infertile, again, infertility is 20 to 30 or 35, 40. But as early as 30 or 28, I had 3 cases of perimenopausal at the age of 28. And they had a hysterectomy just because of fibroids and all that stuff. So perimenopausal is what my other issue is. I want to stress as much as menopause because we can prevent a lot of things in the perimenopause. Perimenopause, today's studies show it can last for 4 to 10 years. One of the gynecologists was shocked to see this. I said, you're telling me the perimenopausal stage is 4 to 10 years? I said, yes, doctor. Perimenopausal is 4 to 10 years before they attain menopause. But where are we missing? We are not addressing it. Kids, people are not coming with those symptoms. They are suppressing it. In India, they just take it, it's females. You have to get a lot of, skin on you have to have a thick skin to take all the crap, to take everything. So we suffer. But they are going through a perimenopausal stage. It is 4 to 10 years. That's one thing I want to address. This is fully. And it is the sign that when you stop bleeding from 5 to 3 days. When the sign that you stop bleeding from 5 and it's only 2 or 3 days, check your hormones. You are under perimenopausal. Check your patient's hormones. They might be in the perimenopausal stage. And because it's too late at hot flashes, I can't do anything about it. So this is coming back to the same slide, DHEA, testosterone, we already went through that. So this is one slide that if you guys want to address, everything is in this one slide. Biochemically, symptomatically, diagnostically, everything is in this one slide. It's a little bit blurry, but I can share this slide with you. So what is stimulating what and what is inhibiting what? If you can address this in this one slide of progesterone and 17-hydroxypregnenolone and pregnenolone and DHEA to the point, so there are two types of estrogen, E1, E2 and E3. Please look at that mechanism if people are confused about estrogen. You need to know what is E1, you need to know what is E2, you need to know what is E3. This is where the whole this thing of prevention of cancer. Again, it's just taken because we are not, again, this is the menopausal biochemical transition pathway. So everything is biochemistry. So this is what imbalances is. This is menopausal follicular cells and the granulosa cells, the cells are going through causing decrease inhibin. When there is decrease in granular cells, they decrease inhibin, there is decrease in negative feedback of biomechanism, pituitary and hypothalamus, there is increase in FSH. So it is the granulosa cells and which are interfering because there is no inhibin and there is decrease of estradiol formation and the anti-Mullerian hormone. Again, estradiol. Estradiol is important. It is a very fine line between good effects and the bad effects of estradiol. We want estradiol to maintain our CNS, vascular instability, urogenital mucosa, cardiovascular and bones too. Symptoms associated, I don't need to go through the symptoms. We all know what are the menopausal symptoms. One thing I addressed in many of my perimenopausal issues are the female is coming with oral mucosal changes. They are coming with aphthous ulcers in the mouth. I looked at the study. There is a similar mucosa between vaginal mucosa and the oral mucosa is so similar. So whenever you come with aphthous ulcers, cracking of the lips, I address hormones. Just because there's a vaginal mucosa, there was a study, estrogen receptors in the oral mucosa are similar to vaginal mucosa. So the natural menopause is defined as spontaneous cessation. Everybody knows about this. Saliva, there is definitely difference in saliva. Salivary changes a lot during the perimenopausal. Dental caries, dysesthesia, taste alterations, atrophic gingivitis, periodontitis. All the dentist takes over all our cases, but they don't address. I have a couple who is a gynecologist as well as a dentist. I said, you know, you both can take care of most of the metabolic things. When somebody is coming gingivitis, please refer to perimenopausal. So these are the oral manifestations that I came across because we don't pay attention. At least it was a news to me when I discovered this only 3 years ago, saying that oral manifestations can be the sign of perimenopausal. Again, progesterone, again, pregnancy, increased in puberty, and periodontal disease, perimenopausal, increased PMS, irregular periods, FSH, LH is elevated, and 80% of them, Americans with hot flashes, fluctuations in perimenopausal and low. So perimenopausal is all this, in this 4 to 10 years, this is what you're going to see. Sometimes it's estrogen dominance too. Too much estrogen in ratio with progesterone. You need to understand estrogen dominance is due to less progesterone because the hormones are similar. Due to less progesterone, the progesterone receptor also occupied by the estrogen receptors, where we have estrogen dominance, and this is where the cancers leads to. So again, estrogen dominance, the clinical symptom and sign is fibrocystic disease, fibroid tumors of the uterus, breast tenderness, water retention, mood signs. Anybody who has fibrocystic disease, I say it's estrogen dominance. And the other hot flashes is fine. So the breasts are responding to the estrogen receptors, fibroids are responding to the estrogen receptors, breast tenderness and mood changes. So the decreased estrogen and progesterone both begin 1 year after the last period. Low thyroid and low adrenals, these are new diagnoses. These are new diagnoses as well as, anything like that. So this is one slide I want to address as. This is where we are. The holistic functional medicine model, recognizing priorities, the patient's full unique story, using fundamental clinical imbalances as a key, treating complexes and chronic disorders. If we can address this as every phase of, counseling, exercise, minerals, biofeedback, acupuncture, therapies, yoga, diet, everything, then we can address so many things. Again, please pay attention to the DHEA, cortisol, testosterone, also when talking about female issues. DHEA is a very, very important hormone. Cortisol is very, very important. High acute stress, so that's why I said stress, high cortisol. So all the DHEA, progesterone are getting diverted to address the stress issues. So the FSH and LH keeps going high and high because the estrogen and estrogen levels are this thing. So chronic high cholesterol causes fluctuations in blood sugar, abdominal obesity, fluid retention, sarcopenia, and low sex hormones. So stress relates to menopause. Thyroid, again, Dr. Sunita is going to tell you a lot about it. Again, progesterone helps convert T4 to active T3. So progesterone is important for thyroid. Progesterone is important for stress, for mood changes. Mood changes, progesterone is important. So coming to just a large thing, adrenal supplements. All that I want to say is currently the bioidentical. So the bioidentical in our clinical practice, the term is originated in the US, but bioidentical is something new and natural. Bio is not natural or from plants. Again, they just mimic to these things. These are the patches that we are doing right now, estrogen, progesterone, combined with estrogen and progesterone. Again, in a tablet form, in an oral form, compared to that, you have, are they registered? No. This is custom made, compounded by compounding pharmacies. In US, it's a compounding pharmacy that we have. Again, bioidentical are more effective, safe, natural, made without chemical synthesis. Estrogen is, again, these are the dosages that we follow in decreasing, but be careful with the estrogen levels with the E2, transdermal, and we have nasal sprays also in US, but here it's unfortunately we don't. So these are the progesterone, again, 200 to 300 micronized, progesterone levels. Again, is it more effective? Yes. Do we have clinical trials? No. Do we have data? No. Can we patent it? No. So we don't have clinical trials on data because you can't patent this bioidentical hormones. Is it safer? Yes. Transdermal is associated with a low risk. Now the conventional therapy of hormonal versus bioidentical hormone is we have a very low risk of blood clots, strokes, and high triglycerides that causes with oral contraceptives. So that's the beauty of bioidentical hormones. When we have to address the bioidentical hormones, this is where. Again, I still don't use my BHRT if any of these people are coming because it's better to be safe than sorry. Approved, again, to obtain approval for estrogen drug, the manufacturers have to conduct clinical trials, which we can't, people are not spending so much money. Again, approval progesterone drug needs 12 to 24 hours of clinical trials. So this is less. This thing, incidence of, again, the thing is, we have to prevent endometrial hyperplasia because endometrial hyperplasia is the one culprit for uterine cancer. So when you do a scan with a endometrial hyperplasia, that is a sign of estrogen progesterone. Endometrial hyperplasia is again due to serum progesterone deficiency. So that's where also you can use a BHRTs so that there's no estrogen dominance and again there's a prevention of endometrial hyperplasia to forming cancers. Okay, that's what it is. Again, it is not FDA approved, sorry to say. But again, in Europe, regulated should be controlled as any other drug. So that's what it is. Now, what does the ACOG do? So everybody wants some kind of a conventional body to address it. In 2014, American College of Obstetrician and Gynecology issued a statement saying that there is no specific scientific evidence to control claims of increased efficacy or safety of BH. So bioidentical hormones. So this is what we have to address, saying that some patients are